First is Dr. Aditya Bharadwaj. Dr. Aditya, you can come and come on the dais. And Aditya is from Amritsar. He's come all the way here and he's going to tell us about conservative management of proximal humerus fractures. We have second speaker, Dr. Harpal Singh. Sir, you can also come on stage. Sir is from Ludhiana. Then obviously Dr. Anup Agrawal is there live with us. He is going to speak on proximal humerus PHILOS plating. Then we have role of intramedullary nails, which Dr. Shailesh Pai is going to talk to us. Dr. Shailesh, you can also take the stage. Then obviously Dr. Dipit is there with me. Dipit, come. So Dipit and me are going to talk from here, and one by one the speakers will come. They will talk about the topic, and then later we are going to have case discussions. So where we want to make it absolutely interactive, because it shouldn't be one way. Then we have Dr. Pravin. Dr. Pravin, please come. Dr. Pravin is with me at Sion Hospital, and he's a big help to me. So he's going to throw some light on literature review. So whatever we're going to talk here, whatever opinions we are going to give here, Dr. Pravin is going to back up everything as per what literature says. So let's start with the first talk. The opening batsman is Dr. Aditya Bharadwaj. So please come.
Good afternoon, everyone. So I'll be talking on the conservative management of proximal humerus fracture. To just begin with, we all know it's more common in females than males, and it has a bimodal distribution. Young males being more affected with the high velocity traumas, while older females are the ones with the trivial trauma. Osteoporosis is the main leading cause. It's the third most common non-vertebral osteoporotic fractures. And what we are more concerned, or the dilemma, is about the older females osteoporotic and how to manage proximal humerus fracture in these. So you all know it has four parts. Well, the supraspinatus displaces the greater tuberosity superiorly and posteriorly. The subscap displaces the lesser tuberosity medially. The pectoralis major displaces the humeral shaft medially and interiorly, and the deltoid displaces the humeral shaft proximally. So we have to create a balance among these deforming forces to have a good result with a conservative management. So for me, the proximal humerus fractures have completed the 360-degree circle. To begin with, everybody said used to conserve these fractures, but nobody liked the X-rays, the malunited proximal humerus fractures, and we shifted to percutaneous fixation, which Dr. Harpal will be telling us. But then they had their own complication of pin tract infections, and then came the PHILOS. We loved these X-rays, and we thought this is the Ramban for the proximal humerus. But then, wrongly indicated, we started seeing these. The PHILOS started to fail in certain cases. Then came the nails, the multi-directional locking nails, and we thought these will be the answers, but nails failed too. And then finally we thought, let's start replacing these in older males because of the high failure rates. But then lately, in last few years, again, we are focusing on, we can conserve a few and start conservatively manage these proximal humerus fractures. So most fractures can be managed. Certain data says, this is not all consensus, but 80% can be conserved. And the indications are very clear. It's older age where the demand is low and the patient is unfit for surgery. If the fracture is stable clinically and radiologically, where there's interdigitation of the fragments or there's impaction, valgus impacted 2 or 3 part fractures can be conserved. The protocol is you can use a sling with an abduction pillow, a shoulder immobilizer, and few papers from Japan are focusing on conserving these in a neutral rotation to have a balance in the deforming forces. Placement of a pad in the axilla helps in aligning that shaft which has gone medially to the rest of the fracture fragments. So weekly radiographs of first 2 weeks to have a close follow-up, bi-weekly till 6 weeks, and the final at 3 months for the consolidation. After 2 to 3 weeks, we can start passive range of motion exercises, better tolerated in supine position, then start with Codman pendulum exercises, active assisted at 6 weeks, abduction we generally start at 8 weeks, and then strengthening by 3 months. Early active assisted motion is the key with pendulum exercises, which leads to good range of motion and good functional results, even though the X-ray looks bad with malunion. Coming to literature, Dr. Pravin will be talking us through in detail, but this was a Proffer trial in 2015 which concluded that there's no significant difference between surgical and non-surgical modalities, and do not support the increased trend of surgery in proximal humerus fractures. But then Proffer trial had its own controversies. 87 patients had clear indication of surgeries but were not included in the studies. 16 out of 125 were randomized to surgery but did not receive surgery, and there were 66 surgeons involved. So it has its own controversies. Hemi and reverse were not included in these. But regardless, this trial supports non-operative management in selected patients. The complications are malunion, though all malunions are not symptomatic, non-unions, and AVN. AVN, a minor humeral head collapse, is often tolerated with minimal symptoms. But for any case, all the three major complications, we have arthroplasty as a backup or a salvage procedure. But to go to is like replacement is better after a failed conservative than a failed open reduction and internal fixation. Though it is still debatable that to do a replacement in acute or a late stage. I think the cases will be discussed. Yes.
We'll just take the second talk now because all the questions and all will be discussed later. So I invite Dr. Harpal Singh. He is going to speak on CC screws and percutaneous spinning.
Good afternoon, everyone. I've been given the task to talk about K-wire fixation and screws. And this has a big part of our clinical practice for proximal humerus. So I'll be talking from my experience and my colleagues' experience. We are a group of people who do this. And I'm not going to talk much about the literature because literature review will be taken up later. And second, the literature available from the Western countries is, I was just discussing with Dr. Pravin, it's old. Nothing new is coming up because it makes no sense to reinvent the wheel first. Second, there are a lot of issues in the Western countries with certain things which do not make sense in India. Like if patient has to visit 3 times for a dressing in a Western country, that's a big negative impact. And our Indian patient would be ready to come for 3 follow-ups without any issues. So what does the surgeon need? You need to know the anatomy of the proximal humerus and anatomy of the fracture. You should be able to make, preferably via beach chair position. We started with supine with the support under the scapula. But if you have beach chair position, it makes your life very easy, especially the manipulation of the fragments. You need a good image intensifier and a knowledge how to use the image intensifier in the shoulder. What views to take, when to take, and how to position your C-arm. And we all do that pre-operatively and mark on the floor that this is the position of the C-arm which is going to work for me in this case. 2 simple instruments are required. One is a periosteum elevator and one is a hook. And that's all we use to achieve our reductions in these patients. And use 1.8 mm K-wires. Don't try to use 1.5. They're not going to work. 2 mm are not flexible enough. In some, I'll mark out, in some positions 2 mm will work. In rest, it is 1.8 which does the trick. So the same again, the Kapanji palm tree, it comes from the wrist. It's a palm tree technique. 3 divergent wires, 3 points of fixation. They spread out in the head of the humerus. You need to drill a cortical hole in the lateral wall to push your wires in. Push them. They are not drilled, they are actually pushed. After bent, you push them up. It's like something like a tense nail, and it provides an angular and rotational stability, right? But all these patients will stay in a brace because if they rotate repeatedly, these wires are going to cut through or they will go loose.
Are they sharp or they are blunt?
Some of them are sharp, some of them are blunt. So it's suited for a fresh fracture, especially an isolated injury. If it's a thin patient, low energy trauma. This is to begin with. Once you become more experienced, you can go ahead and do it in many kind of patients. Geriatric fractures, majority of the injuries, except when it's a dislocation. Don't try it in a dislocation, it won't work. Patient has to be cooperative. And young patient, if it's a simple configuration, you can try it. In young patients, function will be different and is more important. So try to achieve the best function in a young patient. And I wouldn't suggest, I don't say we never do it, but I would prefer to go in for a better fixation device in young patients who are active. So it allows collapse, more biological, minimal blood loss, requires less armamentarium and less costly. Biology preservation is very important. You know, the surgical trauma to the shoulder is the main culprit for stiffness after surgery. And it's easy. So challenges, just to show you a few cases, this is the kind of pre-op we had. This is what I was able to achieve. This is the after removal, and this is the function in an elderly patient. She's 67. Another patient, again, a 4-part, he's young. Slowly over a period of time, we have started taking chances, united, and this is the result. I'm not saying I'll achieve this result in every patient, right? Another 70-year-old obese, good reduction. We were able to achieve a good anatomical reduction, and this is the kind of function, right? They will have some soft tissue components, so it's not possible to guarantee them. We always tell them, I can give you 90 degrees of abduction, and we don't promise more. If they really require more, I'll go for an open reduction and plating. That's an honest confession. So close reduction in K-wire, useful weapon in a surgeon's armamentarium, you must know it, has several advantages over plate fixation, especially in elderly patients. Good patient selection will give you good results. This is not for every patient. Thank you.
Thank you, sir. Now we have online Dr. Anup Agrawal will be joining us on Zoom. Can the AV guys connect him? Yeah.
So, hello everyone. Is my screen visible now?
Just wait for a minute. Yeah, it's available. It's there, sir. You can start.
Okay. So, okay, I'll be speaking on proximal humerus fractures, how to fix them, and the keys to success. So there's some important facts which you should know, how to reduce them, how to fix this tuberosities and what is its importance, how to place the plate and screw properly, what's the significance of calcar screw, and is medial augmentation required or not. So if you compare, is my screen visible properly or there is an issue?
Yes, sir, it is visible, sir. We can see.
Okay, thank you. So if there are two pictures, one is of intertrochanteric fracture, another is proximal humerus. So if you compare the intertrochanteric fracture with proximal humerus, you will find a lot of similarities. So what you have is, in this, you have a greater tuberosity, you have a head fragment, you have a lesser tuberosity, and then you have a shaft with medial column or the medial comminution or medial stability. So if you compare these two, they have a lot of similarities, and this is what is you required. These are the 4 fragments which you need to reduce actually, and you need to understand the anatomy of it, that where they actually go. So by Aditya had already told that how the fracture fragments are being pulled by the different muscles. But what is more important, to understand the head, though it does not have any muscle attachment, but normally it goes posteriorly and inferiorly. So with this knowledge that how these fragments are placed or displaced, the first aim is to reduce the head. If out of these 4 fragments, first aim is reduce the head, bring back the tuberosities, lesser and greater tuberosities, and then align all these fragments to the shaft. Now, when I say alignment, it is the head shaft angle which is needed to be aligned well, and we need to align the medial stability, the medial comminution or the medial cortex. Why it is important? It has been very well established that maintaining the head neck shaft angle induces the lack of medial support, and it has a prognostic factor that can lead to a poor outcome if it has not been maintained. So that is our aim to achieve. Now, how to do that? So if you have a varus fracture, then you have to reduce head either by putting a K-wire, then manipulate, or you can put an periosteum inside the fracture and then reduce back, or you can use the suture wire and then put back the head. A word about where to put your retractors. Most of the time, what we see, since it is in the head in the varus, we try to put your retractor or some instrument onto the medial side of the head to push it back. Never ever try to do that, because that's the only vascular supply to head which is remain. So if you have to push any fragment, your finger or any instrument, it has to be through the rotator cuff interval from where you can push back. So that is how you do the varus reduction. For valgus, it's much simpler to reduce a valgus fracture. You just put a periosteal elevator inside the fracture fragment, reduce it. Once you have reduced the head part, now next target would be suture back the greater tuberosity, pull it from the posterior of the tuberosities. I suture them together along with the head. So this makes one fragment: head, lesser lesser tuberosity and greater tuberosity in one fragment. And then you can see in this picture, then I align it to the shaft. So this avoids the placement of lot of K wires, and then you can place your plate well. There are no hindrance of the K wire. So once you have done, now the most important aspect is that medial reduction. That is aligning your proximal fragment to the shaft. We all know that PHILOS can be used as a reduction tool, but if you have a varus collapse, in that case, if you're putting first screw into the shaft, it will further push the head. It won't reduce. So what you need to do is, you need to first put the screw at certain angle depending upon the amount of displacement into head, and then adduct the plate to the shaft and then put the shaft screw. That is how you will be able to reduce in varus. While in a valgus fracture, if you're putting your first screw into the shaft, it will reduce the valgus fragment into its position. So the trick to use the PHILOS or the plate as a reduction tool is different for varus or a valgus fracture. This is how you do it in valgus. Once you have done all that, I again put my sutures back into the holes which are there into the plate, then align my plate and put on zig, and then I place all my screw. Now, what about where you should put your plate? Your plate should be 20-30 degree angled and lateral to the bicipital groove, and it should be distal to the tip of tuberosity. What about cautious? That never use the most proximal hole and put K wire to align your plate. Always align your plate with the zig. If you're doing it with the K wire into plate, you will always be wrong. And align your plate in both lateral and AP. Once you have done the alignment, pass your screw. Always check your screws in all position. A word about TAD, like in intertrochanteric, you have 5 to 10, but here in proximal fracture, you have to be as close as possible to the articular surface, but never ever penetrate the articular surface. Keep on rotating and checking on different view about the penetration of articular surface of the screw. A word about calcar screw. The n number of studies, Dr. Pravin would be giving you the data about this, that loss of medial support is the most common reason for secondary displacement. And that's the reason all these studies have proven that having a calcar screw further strengthen the medial stability. And how you place, whether everybody needs a calcar screw? No. If you don't have a medial comminution and if you have a medial continuity, probably you don't require, like in this case. But if you have a medial comminution, then you will require a calcar screw. And even after a calcar screw, you don't find it is stable, then probably you will need some of the osteobiologics like bone graft or fibula straight or a iliac crest graft, or if it's not available, then you can use the bone graft substitute. And there are n number of studies which have proven that adding these biologics add to the strength and union of these fractures. So rehabilitation depends on type and quality of fixation, associated injury and patient compliance. So I'll conclude by quoting this study that a majority of displaced fractures treated conservatively with early physical therapy. Treatment for displaced fracture should be dependent on the patient's level of independence, bone quality, surgical risk factors. Fixation with percutaneous technique, intramedullary nail, locking plate and arthroplasty, all are acceptable treatment options. Mind it, there is no clear-cut evidence-based treatment of choice for every patient. So you need to consider your own comfort level, your skill, patient condition to decide and in having a decision making. Thank you.
Thank you, sir. Thank you very much for coming online. And we will continue with our talks. Dr. Shailesh Pai is the next speaker. He is going to speak on intramedullary nails for proximal humerus fractures. Over to you.
Sir. So my job was to speak about intramedullary nails, and I was given 3 minutes for that. So whenever we speak about implants for treating anything, a couple of questions come. Number one, how to do it? Number two, when can we do it? And number three, of course, we would like to know what literature says. So literature will be shown by Dr. Pravin. So the first part of how to do it, we have covered that in the workshop. Many of you were there. And so today I just thought we'll just show some cases of when can we do it and take questions so that we have more time for discussion. So number one, I have kept 2-part out, 3 and 4 parts, all the complex situations that we can think of. Here is a 4-part fracture. So as long as we could get a good reduction, good valgus reduction, get the tuberosities back, which is the key factor, we could nail it. Union is not much of a concern. The patient should be doing good. Elderly gentleman, posterior dislocation neglected, 70-year-old, 6 weeks presentation. Again, same principles, reduce them, get the tuberosities back and fix them with the nail. Nail should do good. Union is not again a concern. And once it unites and the tuberosities are back, range of movement should be near normal. Head split fracture, I'm pretty sure all of us agree that it's one of the most toughest subtype of a fracture in the proximal humerus to treat no matter what age. This is a pure head split in a young gentleman. Again, same principles, reduce it in valgus, get the tuberosities back, the nail will do the job. That's him immediate post-op at union. That's his range of movements. I have his consent for showing his face in the video. This is a head split in mid-30-year-old gentleman, software engineer by profession. Segmental fracture is one more other fracture which is little tough to treat with a plate or most other devices. Again, with a nail, we do not bother about what's happening to the shaft. All we need to do is get a good reduction in the head. Once the nail goes into the distal part of the shaft, the alignment is more or less by itself. So this was again a 4-part fracture in the proximal humerus, very well easily be treatable with a nail. That's him at his union and the range of movements. Anatomical neck fracture in elderly, again concern because anatomical neck, it's a little tough to do this with a plate. So many of us start considering whether we need to replace it. We get CT scans and see that the percentage of bone is less than 30%, 25, 15 sometime. But remember that CT scan does not give us all the information. That is why, if you can see, the head is not just rotated, it is tilted. So when the scans are taken at fixed definitions. So maybe at that particular position, we are seeing only some small part of the head, but the entire head is actually there. Unless it is a head split or head fragmented fracture, all the head is there. That was what the head the patient had all these years. So we can't be thinking that the head is not there because it's not an open fracture, there can't be a bone loss. So anatomical neck fractures, again much easier to do it with a nail. Get the valgus reduction, get the tuberosities back, good entry, and we could do it with a nail much easily. That's at union. So the last case I will be showing you is significantly comminuted fractures. What do we do in them? Again, we all know as long as the biology is preserved, union should not be a challenge. So neck shaft angle, get the neck shaft angle well, tuberosities well. This was an open fracture, nail them. Healing should happen, luckily, thankfully, whatever you want to call that. But since the biology is preserved, union should be there, and that's the range of movement. So take home message is, we all know nails are significantly biomechanical advantage over most other fixation device in proximal humerus to take off all the mind blocks from our head. It could be done in all subtypes of fracture, no matter what we're talking of, 2, 3, 4 with dislocation, without combination, anatomical necks, segmentals, head splits, everything. Learning curve actually not that steep. Once we have done enough femur nailings and we all know how to do them, humeral nailing is much more easier. So it's not that steep, so I think we should all be considering them. Thank you very much.
Thank you, Shailesh. Only one important point which I want to ask you, you can take the mic. The cases that you showed, are you taking a rotator cuff suture through the displaced thing, or you are just putting the nail inside and expecting the tuberosity to sit back?
Tuberosities won't sit back. We need to get the tuberosities
We need
back.
to take a suture through the tuberosities. Our next speaker is Dr. Dipit Sahu. He is going to teach us about how to do a good reverse shoulder for proximal humerus fractures.
Thank you, sir. Thank you, Chairperson, and thank you to all the audiences. Now, I'll be speaking on reverse shoulder, but let me start off by saying that this is less than 10% of the proximal humerus fractures that are replaced in my practice. Most of them can be conserved or plated. Reverse shoulder, even though I'm speaking about it, will be showing you good results, but they are very small part where fixation is not possible. Even conservative may lead to bad results. And when to do it, why and how to do it, I'll give you 3 indications where you should do it, and all those indications are examples where you cannot probably conserve them and probably cannot plate them, at least I cannot plate them and give good results. So this is one. So head is dislocated in an elderly individual. There is no soft tissue attached mostly, and if you see, I cannot get the head back to the glenoid without stripping the soft tissue. There are some times in a dislocated fracture where I can. In this one, this is too far displaced and dislocated. I cannot bring it back. So this is one classic example where I would do a reverse shoulder, not hemi. I'll tell you why. Second is, it's just badly comminuted. It's just 5-6 part fracture. It's just so many fragments. Head is split. It is a very futile exercise. You go on fixing each and every fragment. You can conserve with bad results, but fixation is bad. So probably these ones also I'll just do a reverse, and reverse shoulder gives excellent outcomes. That is a proven thing. Now, and this is a third, also one of the few first cases when I started doing reverse and fractures were the sequelae of failures, non-unions, PHILOS failures, malunion, avians, all sequelae of PHILOS failures. For example, in this case, the head is gone, the screws are going in, there was a non-union at the neck level. So this one also cannot be salvaged by any other methods. And hemi is not my go-to procedure. I've stopped doing hemi for the last few years. So I always, it has to be replaced, it has to be reversed. Hemi is a bad option, just doesn't give good results in most cases. There's a less likelihood. So these are the 3, and this is another sequelae, a non-union, a 1-year non-union, which was not amenable to any other treatment, and we just did a reverse, and they get acceptable functions even in these, although it's the second time you're operating. Your second time you operate in a shoulder is never good. It will give you inferior results, the movements are less, fibrosis is more. But then, even then, reverse still gives some acceptable movements. If you see, ROMs are always good in reverse. Not always, if you can say, most of the time they are. So indications 3, always remember these. Head has less likelihood of survival, just badly comminuted, and sequelae. Now, why not hemi and why reverse? This is a good question. Hemi has just fallen in disfavor. Most of the shoulder surgeons do not prefer it. I just don't prefer it. I just don't do it in last few years. If you see, this is a hemi which had a badly comminuted, my own case, my own failure. Badly comminuted GT, tried to reconstruct it. Post-op day, it looks okay. 6 months later, if you see, the head has gone up, hitting the acromion, is complete failure. The GT, mostly whenever there is comminuted, just doesn't unite, just doesn't heal to the shaft. The GT has to heal to the shaft. It doesn't heal to the prosthesis. Has to heal to the shaft. It doesn't heal. Even a good-looking X-ray fails, more chances of failure later on. So hemi, probably not a good choice. Now, I'll just show you this. So, if you see in the first X-ray, I did a very good GT reconstruction in the reverse. The GT did not unite. Even in a reverse, it did not unite. So, it may not unite even in a reverse, but the reverse doesn't care. Reverse doesn't matter. It doesn't matter if the GT unites or not. It will have a good function because it only needs a delta. Delta it is functioning. GT unite, doesn't unite. LT unite, doesn't unite. It doesn't matter. You will have a good function irrespective of the GT healing. Not so the case with hemi. Now, 3 technical aspects I will just give you. Again, 3, lucky number 3. So always remember 3 points. So 3 technical aspects why when you're doing a reverse in fractures, couple of things to take care. Now the humeral stem is the most concerning thing, and 3 things are most critical: how much to keep in, how much to keep proud, retroversion and GT reconstruction. Glenoid base plate is very standard mostly. If you do a reverse, it's just like that. So how much to sink in, how much to keep proud? We published this cadaveric study with Dr. Jairam. If you see 53 millimeter was the average distance from the pec major upper part of tendon, the humeral head is 53 millimeter. This is a published study by us. So 53 millimeter, the metal part of the humeral tray should be kept superior to the pec major tendon, 53 millimeter. So this is a approximate landmark that you can always I sometimes rely on if I don't have a matched X-ray from the normal side. Now how much to do a retroversion? So again, you don't have landmarks, metaphysis is broken, GT broken, everything in the proximal part is broken. How much do you do a retroversion? Normally we do a retroversion in the normal retroversion of the patient. The patient retroversion is not possible here if you don't have an opposite side CT scan. So 25 degrees is an average retroversion that we have found in a study, published study again. So 25 to 30 millimeter is average retroversion of human Indian population. So that is a ballpark figure, and you don't know the person's, this patient's retroversion. I keep around 25 to 30 because that is what an average Indian female or male will have. So I tend to keep around 25-30. And the GT repair, if you know the designs, the 135 or 145 is better than the older 155 angled prosthesis of reverse. They allow a better tuberosity reconstruction. Now even then they may fail, but we do it still in the beginning to give some soft tissue support. So summary, just if you can keep in mind, the technique of humeral implantation is important, how much to sink in. Functional outcome will be excellent if you keep in those points in mind, and reverse is any day preferred than hemi now in elderly patients. Thank you.
Thank you, Dr. Dipit. Our last speaker is Dr. Pravin. He will back up all the talks with review of the literature. Dr. Pravin, you can come over. And last, I think we'll take the questions, or maybe we'll take some cases. So whatever the audience wants, because we'll be left only with 5 minutes.
So good afternoon all. Now I am starting with the review of literature after all these talks. So in all this talk, the classification which was followed is a NIRS classification. So let's revisit what is the NIRS classification. This was the article which was published in 1970 by Dr. Charles Neal. It clearly mentions that it is a displaced fracture which matters. Number of fracture line does not matter if the fragments are not displaced. This is a review of your conservative treatment for proximal humerus. This is a proffer trial that Anup Agrawal has just described. So proffer trial, it was a randomized control study between the surgical and non-surgical treatments. So 250 patients were enrolled for it, and they were followed for 2 years. Since it was a randomized control study, it has had a high level of incidence. But if we delve deeper into this trial, it just mentioned whether it was a tuberosity involvement or not. It does not mention how much separation was there. It does not mention whether it was a 2-part fracture, 3-part fractures. Then this is a conservative treatments systematic review published in 2020. It was from PubMed and Cochrane databases for last 20 years. It shows that 3-part fracture has good functional results, where the 4-part fracture with conservative treatment, they show the poor functional results. So the PHILOS is a go-to treatment for most of your proximal humerus fracture, for most of us. But still PHILOS, we face some failure rates. So we try to analyze whether there was any inherent fracture patterns which leads to this. So this is the article published in 2009 in Journal of Orthopedic Trauma, which shows the varus angulation at the time of presentation has a poor outcome, and if it is metaphyseal segment of 2 millimeters attached to the articular fragment, the chances of avian are less. So similar study was done in 2016 in Journal of Injury. It shows that initial varus has poor prognosis. They studied 101 fractures for nearly 1 year. The 14 patients need reoperation and 3 patients needed conversion to arthroplasty. And all the patients who had a varus alignment at presentation, they needed conversion to arthroplasty. So the importance of the medial support in the locking plates means it has been very well described in this article, from 2007. The 35 patients, they were followed up to the fracture healing. They define medial support if the medial cortex is anatomically reduced or if there is an inferomedial screw in the proximal fragment through PHILOS. So they found out that if the medial support is absent, there is a reduction is lost while during follow-up. So this is a recent study in 2018. So they try to find out which type of fixation is better, whether it is inferomedial screw is better or whether any structural allografts, they will be having a greater impact. So this study, they studied about around 164 patients. They classified, they distributed like this, like 80 patients were treated by inferomedial screw and 84 patients they treated with the fibular allograft. And 164 patients all had a comminution on the medial side. So they found out that these 4-part fractures where the allograft was used, allograft was useful in these patients. Functional outcomes in 3-part fractures with the fibula allograft and inferomedial screw was normal. Like in the functional outcomes in the 4-part fractures with inferomedial screw was lower than their fibula allograft. So coming to the literature review of nails, so we stumbled across this book, Simple and Complex Fractures of the Humerus. It was published in 2015. And this chapter, the intramedullary nail for the proximal humerus fracture, old concept revisited. This author, according to author, the older proximal humerus nail, they had a lateral entry point. This led to the greater tuberosity fractures and further complications. So this author advocated a medial entry point and smaller short diameter nails. So this is the example of the older nails which is having a broad diameter which used to get locked up distally and which leads to the non-union. This author further describes the hip fractures and the shoulder fractures are not equivalent. In shoulder fracture there is a horizontal pulling force. If we follow the classic AO teaching, the direction of our screws has to be perpendicular to the fracture. Now, the fracture line between tuberosity is at here. So, the screw direction has to be perpendicular to this and not like this. So, can we use nail in all fracture types? So, this was studied in 2015. This was a review article. They studied up to 14 studies with 448 patients. They found out that reoperation rate was higher in 4-part fracture which was done with nailing. Can we do nailing in all fracture types? So this was studied further in 2015 in European Journal of Traumatology. They improvised the needs classification, and according to they classified it as whether it is articular involvement, whether there is a surgical neck involvement, whether there is tuberosity was involved. And they found out that the displaced articular fracture, this is the A3 type, they needed arthroplasty. This is further last study on the nail in all fracture types. So here they found out that functional outcome was similar in 3 and 4-part fracture which are treated by nails. But these authors emphasize the quality of reduction has a strong influence on incidence of postoperative or vascular necrosis. If you are not able to get a reduction by nailing, you have to change your surgery. So these are studies which compare nailing with plating, and they found out there was no significant difference between nailing and plating. But yes, nailing has a less blood loss, less operation time. This is a study in 2015 which found out that if there is a medial hinge at the time of presentation, then functional scores are better with plating. Then finally, this review of literature of the reverse shoulder arthroplasty in proximal humerus fracture. The functional outcomes are good at the 1 year, and complication rates are less. This is another study from 2017. It shows that with reverse shoulder arthroplasty at 1 year follow-up, 91% of patients, they reach the pre-trauma independence level, and they don't have to take higher doses of analgesics for pain control. And finally, this is a study in 2017. Here, the patients, they compared the patient who have been advised the reverse shoulder arthroplasty with the patient who have undergone reverse shoulder arthroplasty. At 1 year follow-up, they didn't find any difference between range of motion and patient-reported outcomes. So, literature for reverse shoulder arthroplasty is still developing. We have to wait. Wait for the further literature. Thank you.
Thank you, Dr. Pravin. I think we are just reaching time. So I think we'll discuss the questions, from the audience. You can ask the questions to the esteemed faculty here, because we had lined up some 4 cases, but I think because of shortage of time, I think it's better we take questions so that, you can clear your doubts. Yeah, Ravi.
Hi. Dipit, one question for you. You already said a redo surgery in shoulder is going to be fraught with its own problems. So when you are opting for re-operation, say planning to do a reverse shoulder, do you do EMG to see the status of the axillary nerve? Because many a times, first surgery you may not have done, somebody else may have done. There is significant damage at times, and you are hinging, your whole reverse shoulder depends on a functioning deltoid.
A very good question. Has been in my mind every time I go in for a revision surgery. And some of them, for example, I did one case, I agree with you that anterior deltoid was gone, only posterior deltoid was left. They don't get good movements. So clinical judgment of deltoid is what I rely on now. So the power, they won't be able to abduct, but I do check the power, atrophy and all that. EMG NCV have not done, but if he has, I don't operate, at least 1 year has passed after PHILOS failures or something. So if you have a good muscle mass still and is able to contract like an abduction power is okay, I will do it. And I have had a failure once which did not have a deltoid. It was completely gone because of the first surgery, axillary was gone. So that is a concern always to check a axillary deltoid power. I agree with you.
Yeah, this question is to all the faculty. There are a lot of controversies about different people talking about ideal number of screws in the proximal fragment in PHILOS plating. So what is actually the ideal number of screws one should have? Because some people say 3 is sufficient, some people say 5 is sufficient and stuff like that. So everybody can take that
so
up.
I'll tell you what this has been my question for the last few years, and I started with 5, 6, went down to 3, 4, and I've done all those 3 screws, 4 screws, 5 and 6 screws also, and I looked up the literature. There's no real clinical literature telling us ki you should do 6 screws or 5 screws. AO says 4 to 5 screws. That's what the AO manual says. Now clinical evidence is not there, and I've done many cases with 3 screws only, because I rely more on the cuff sutures going through the plate. So angular stability is I achieve by the cuff sutures tied to the plate. So that is what I rely on more. But we can go through each one of them.
So I would say it's the reduction which is going to hold your construct rather than the plate. Second, depends on the bone quality. Third, how good is your spread with the screws? If your screws are well spread into the head, 3 may do. But when you are putting in the screws, I want to know the other side, Dipit. I want to know the other side. What's the harm in putting a 4th or a 5th screw?
Yes. So the harm, as I have seen in my cases, 25% of screw removal because of screw going in. Because if there is a mild collapse also, I've seen a couple of patients, I've removed the screws. So that is the only hardware, more chances of complication. That is the only thing.
In my practice, the main is the calcar screw. If I'm getting a calcar screw and then the 2 divergent screws, they are the main 3 screws I'm focusing on. I might add additional 2 convergent screws if I feel that the bone quality is not that good. But that 5 is the limit for me. But the most important is the calcar and the 2 divergent screws which hold the spread of the head.
Dipit, can I take a...
Yes.
My question is, how important is pre-operative CT scan to know more in osteoporotic fractures where there might be a void and you might be required to fill in with augments and again that number of screws?
So we'll start.
I think it's almost 100% of the time, at least in our situation, we need to be doing CT scan if we are thinking of doing in 3 and 4 part fractures, definitely in elderly. More than the void, what we are actually concerned is number 1, head split. Number 2, the pseudo splits. Many times the lesser tuberosity takes a part of the head and also the greater tuberosity takes a part of the head. In these cases, we need to be able to, tackle them better. So also 2D CT more important than 3D because we will know how much real quality of bone is there. So almost 100% of the time we'll be getting a CT scan.
One question to Dr. Singh, very simple. You have shown beautiful slides with 1.8 or 2 mm K-wares. My simple suggestion is threaded K-wares are better to avoid proximal migration, which is very frequent problem.
Threaded while putting through the soft tissue can be a very big problem, and we have had muscles. We were lucky, no neurovascular structure got caught. And even while removal, it can be a very big problem.
Yeah, but what about the proximal migration of the K-wares, especially?
Ideally, the first wire is a sharp wire. Rest of the wires can be cut and then put through like a 10 nail. I will say we have had wires which have cut through the head, but when you mobilize, you remove and mobilize, it doesn't affect the result.
I think we'll have to wind up this session because the next session is supposed to start in another 3 minutes. Thank you very much, faculty. Thank you, chairmen, for chairing this session. And my co-convener, Dr. Dipit, thank you very much. The faculty is going to be available outside during the tea break, so you can ask them whatever questions you all have, because we have to give over this hall to the next session. So I hope you understand my situation. Thank you so much.
Yeah. So, good afternoon, and we are all set to start with the session on to neglected foot and ankle trauma. Is salvage possible? And can I have my presentation? Okay. Who is there from organizing team? Can we have the presentation here? They are putting up? No, it's seen here, it's not. Okay. So the learning objective of this session is discuss the unique clinical scenario in neglected foot and ankle cases, outline management options with a specific focus on the salvaging the joints. Yes, we know that fusions can always be done, but we are trying to talk about the salvage. We need to highlight finer details of management, including timing, details of procedure, choice of implant and approach, and steps to avoid and treat complications. So for this, we have our esteemed panelist, Dr. Asim Negi from Indore. He is a renowned trauma and reconstructive surgeon, interested into management of complex trauma and non-unions. He is also a national faculty for AO and has had presentation at various state and national conferences. We have Abhishek Kini, who is a consultant foot and ankle reconstruction surgeon with special interest into sports medicine. He is attached to Hinduja Hospital, Reliance Hospital, Jupiter, Lilavati, Bridge Candy. Dr. Negi, if you could come and have a say. Abhishek would be joining us in a minute. We have Dr. Rahul, he is a consultant foot and ankle surgeon from Rajasthan Hospital, Executive Committee member of Indian Foot and Ankle Society and Sikot Foot and Ankle Society, and he is a founder, Jaipur Foot and Ankle Society member. Unfortunately, he could not make it, so we're just going to go through his presentation. And we have Dr. Girish Motwani, who is a specialist foot and ankle orthopedic surgeon from Nagpur, and he has been Executive Committee member of Indian Foot and Ankle Society and is carrying a very big responsibility of organizing Indian Foot and Ankle Society's annual conference for 2023. Girish, can you please come up on the dais? And I am Rajiv Shah. I am foot and ankle surgeon from Baroda, immediate past chairman of Asia Pacific Foot and Ankle Council and past president of Indian Foot and Ankle Society. So with this small introduction, let's start ball rolling. What we'll do, we all would turn by turn present a case of neglected foot and ankle trauma, and we'll come up with how did we manage it. And then we will leave it to floor to ask questions, to bombard questions to any of the panelists. So here comes the first speaker, Dr. Asim Negi. He is going to talk about neglected ankle fracture management. Over to you.
Yeah, thank you, sir. Can I have the first slide? Please make it slideshow. Yeah, thank you. This 41-year-old lady who is a software engineer working from home in Hyderabad, she had a fall at home, and at the peak of COVID was treated by some osteopath, some splintage and other things, and 4 months down the line, this is her X-ray. Another 2 months passed by before she sought treatment because pain was increasing and she wasn't able to manage her activities. This is the stage I saw her. We got an X-ray of the opposite normal ankle done so that we know the parameters which we have to restore. Friends, remember that the ankle mortise is like a ring, and ring has to be reconstituted for regaining stability. Remember that normal parameters of the ankle joint, the dime sign has to be restored by restoring the length of the fibula. On the AP view, as you can see here, distal tibial fibular overlap has to be more than 6 millimeter, and you should have equal horizontal and medial clear spaces as shown by the arrow on that AP view. On the mortise view, tibiofibular clear space should be less than 5 millimeter. That's the normal. So this is what we are striving to achieve. In this patient, fibula is short, anteriorly angulated as you can see here, and it's small rotated. So these are the three things we have to correct in the fibula. These are the sagittal and coronal images there. Medial malleus is a very tiny piece. Talus has shifted laterally and is tilted also. Fortunately for me and the patient, posterior malleolar fragment was there, but it has united in good position, and the syndesmotic notch doesn't look really bad. We operated the patient under spinal anesthesia in the supine position. There is a bump under the hip, tourniquet. I have marked the incision for my anterolateral orthotomy for open reduction of syndesmosis if I finally need it. I marked the posterolateral incision, but we started with a smaller medial incision because unless you clear this medial gutter, you cannot bring back the talus there. There is no space at 6 months. It is all filled up with fibrous tissue. With the help of thin periosteum and the artery forceps, the medial malleus has to be demarcated under image intensifier control. It's not easy at 6 to 7 months to even find out where the medial malleus is. We located it, then we took a flexible osteotome, thin flexible osteotome, and osteotomized to open the non-union side. Please remove all the fibrous tissue from the medial gutter to make place for the talus to come in. Then a long posterolateral incision, perona have been retracted posteriorly. Knife can cut through the fibrous tissue in the non-union site and recreate the original fracture again using a thin osteotome as we have done here. freshen the fracture ends, open medullary canal on both the sides. Lever out fibula to length as much as is possible without using a distractor. First, reduce and clamp a 10-hole 3.5 locking plate there and fix the distal fragment with K-wires. At times, if the distal fragment is short, then your distal K-wire fragment, you can pin it to the talus even, so that the fibular length, whatever is normal you want to restore, it is fixed. Fibula, you can see that is stitched short by few millimeters. So you complete the fixation of the distal fragment. In this patient, we chose to pass a 2.7 millimeter cortical screw in the proximal fragment, closer to the fracture site in a combi hole, which is fairly long, 7-8 millimeters is there, but not fully tightened. This screw will ensure that the fibula is lengthened along the desired axis, and then we pass another screw proximal to the plate and use a cervical interbody distractor, like the picture is shown in the picture, and regain those few 5-6 millimeters. If I needed more length to achieve, then probably I'll have to back out that 2.7 screw, complete the proximal fixation, and then pass a syndesmotic screw or a guide wire, and burr out the sclerosed medial malleolus non-union site. You will have to clear out the fibrous tissue, remove extra bone medially on the proximal fragment, pass a joystick in the medial malleolus because it's a tiny fragment, it's difficult to hold it. Periosteum in the medial gutter is pushing it so that Shenton line can be restored. Pass K-wires perpendicular to the fracture plane. Here the plane is distal anterior to proximal posterior. Tension bend completed. This is her immediate post-op. At 2 weeks, she has got a fairly good range, no plaster. 6 weeks, 3 months, and this is her 2 years follow-up. She is back to her normal. She can run, she can dance. That's her gait. So key points here to remember are: attempt a reconstruction of a malunited ankle except in cases with significant severe arthritis. Minor arthritis, please reconstruct the ankle. It will last at least 10 years for that patient. And restore the fibular length and rotation. At times you will have to use a tricortical strut there, restore talus in mortise, correct tilt, fix medial malleolus and the posterior malleolus if required, reduce and fix the syndesmosis at times with open reduction, and all this in old cases will require extensive soft tissue release and clearance of the medial gutter. So don't shy away. Thank you.
As I said, we'll take questions onto every case once we finish the discussion. So I'm going to talk on to talus. Yeah. Presentation. Click onto the presentation, please. Okay, this is what I need to do. Okay, so neglected talus injuries. I'm going to talk about 3 different case scenarios, all adult patients, almost of the same age group, and all either neglected, untreated, or poorly treated talus injuries. A 5 months old neglected, untreated trauma treated by a quack, and these are the CT scan pictures. There's a sagittal image, comes like this, and it's a non-union or the malunion, whatever you call it, is just 5 months old injury of body of the talus. This is the case number 2, 3 months old neglected, poorly managed trauma, where 1 or 2 K-wires were passed and the whole comminuted medial half of the talar body was lying like that. This was the situation at the end of 3 months when he was sent to us. That's the skin condition, and this is how it was: fracture neck talus plus lost medial half of the talar body. Another case, 18 months old neglected, poorly treated trauma, medial malleolar osteotomy was done, posterior anterior screws were passed for fracture neck talus. And these are his clinical pictures. You look at his foot, there is cavus, there is varus, there is equinus. And so these 3 similar situations, untreated neck, body fracture, a treated fracture, poorly treated fracture, and again poorly treated fracture with some arthrosis, malunion. And then question is salvage possible in these cases? Otherwise, we traditionally know that such malunions, they go into tibio-talocalcaneal fusion. So let's see how we salvage all three cases. The decision making for neglected talus injury is the age, activity of the patient, duration of the malunion, what is the status of the joint, and whether avascular necrosis is there or not. Some little points of low significance are deformity, status of the soft tissues, quality of the bone, and comorbidities. And the salvage options could be revision fixation plus osteotomy, partial or total talar allograft replacement, and very recent is total talus replacement. So case 1, 5 months old neglected fracture, double approach was taken, and this is how the picture looked. This is the fracture line. It was opened up with a sharp osteotome, and fragments were mobilized, and ultimately the fixation was done, and this was the on-table fixation. That went on to unite without any avascular necrosis, and these are the movements of this patient. That the case number 2, 3 months old compound lost medial half of talar body with fracture neck femur, neck talus. So debridement, VAC, external fixator was done in stage 1. Antibiotic impregnated cement spacer for the lost medial half of the talar body was done. Expix was removed at the end of 6 weeks. Parameters, serological parameters were good. Allograft talus was procured of a reasonable same age, obviously not the same size, and ankle salvage was aimed at, where the matching of the half of the allografts was done with that of the remaining talus at the level of the ankle joint. It was fixed, and neck of the talus was also fixed and grafted. This is how it went on to union, and this is the function of that patient at the end of 1.5 years. In the last case, 18 months old malunion with ankle and subtalar arthritis. CT scan of the opposite side was done. 3D printed file was created, and 3 models plus and minus 1 plus 0 were created. With an anterior approach, talectomy was done, and implantation of the 3D printed total talus was done. This were the online on-table movements, and some additional procedure in form of tendo-Achilles lengthening, lateral sliding calcaneal osteotomy, hammer toe correction of the great toe, and plantar fascia release was done. And this is the result of this patient, where total talus replacement was done. These are his movements, and he is back to his normal activity. Thank you very much. Please come on the dais, sir. He is also one of the candidates. Sir, please. Yeah, sir, please come.
Good afternoon, everyone. Post-lunch session. Thank you for being here. So I'm going to be talking about calcaneum fractures neglected. So the reason neglected is, like, we see a lot of them neglected, and that's the importance. So importance of calcaneum fractures being an intra-articular fracture, it's important that if we don't neglect a tibial plateau, then why neglect a calcaneum, which is also a weight-bearing intra-articular fracture? Assess the deformity and act appropriately. So this is the case of a 24-year-old male, had a fall 9 weeks back, was treated in a slab for 4 weeks, and then a compression bandage for the following 3 weeks. He's an office goer. He travels from Badlapur to VT to go to work, and was told that eventually you'll have pain, and then let's see how things go. So at this stage, with this deformity and fracture, how many would offer a refix to this? Just a show of hands. 1, 2, maybe 3, 4 or 5. Okay. I think CT, we'll come to that also. So even if say like the CT is bad, but still I think there are less courageful people over here than the remaining. So again, the case, again it's an intra-articular fracture. You see that the main fragment is depressed. You see a deformity, that's quite a significant varus. Yes, the question is cartilage. At 9 weeks in a 24-year-old man, would you consider like burning the cartilage down and offering him a direct fusion or something? Because he's not able to travel now. So I did an open reduction. I got the lateral wall down. We elevated the fragment. Yes, CT didn't play. There was a video of that. So on CT, in fact, he also had an MRI, which showed that the cartilage was relatively well preserved. Like for me, the subchondral bone on the cartilage, is very important. If it shows rarefaction, I am skeptical of the cartilage. So it's like an indirect indicator for me. So in this guy, yes, we consented everything. We elevated, held it with a K-wire. We corrected the varus and we fixed it. Yes, intra-op, I've kept one wire there to go right through the subtalar joint. So this is what it looked immediate post-op. You see there is disuse osteopenia right now. Eventually at 1 year, this is the picture. He's resuming all his office duties of coming in a local train in a Mumbai traffic and is able to do most of his stuff comfortably. So this is a case where we attempted a refixation for this deformity of calcaneum at 9 weeks. So by the time he came on table it was 9.5, 10 weeks and went ahead. Thank you.
Thank you. Thank you, Dr. Kinney. The next topic is salvage of neglected metatarsal fracture. As Dr. Rahul Upadhyay is not there, Dr. Rajiv Shah will take over.
So it's a case of Dr. Rahul who could not manage to come. 22 years old young male had a pain in the right foot and difficulty in walking with a plantar callosity, and he had a history of road traffic accident. You can see the plantar callosity and thickening, and it was like malunited third and fourth metatarsal with an angulation showing a plantar flex metatarsal. And this is the maestro's line which shows that this metatarsal is quite short. And please shut off the alarm. We are taking less time than what we are given. And this is how the transverse parabolic arch of the foot was lost. And so the options for him were condylectomy, resection of metatarsal head, or salvage with osteotomy and deformity correction. So mind you, what we are trying to show here are all those foot and ankle fractures which can be salvaged, malunited or neglected. So Dr. Rahul wanted to go ahead with salvage. So he opened it up with a incision, and then this was the dorsal bump, that was the head of the metatarsal, and then a dorsal close wedge osteotomy was done, fixed with a K-wire, and this was the final picture where you see that the plantar flex metatarsal is corrected, and this patient went back to his routine activity. So take-home message is dorsiflexion metatarsal osteotomy is a good salvage measure for neglected metatarsal fracture. Intractable plantar keratosis need treatment of the root cause because the cause is the pressure of the metatarsal. Maestro's lines are excellent guide to assess the abnormal metatarsal. Thank you very much.
Thank you, Rajiv sir. Thank you, Team WIROC, for inviting me for this STEAM conference. So my job is to talk about, is the salvage possible for the Lisfranc injury? So He is a 35-year-old male. He had a history of trauma due to fall from stairs. Went to a local physician. Got an X-ray, found that there is nothing on the X-rays, and he has been treated with a simple crepe bandage, but he has a pain and the swelling all around the midfoot. And these were the location of pain and the swelling. 15 days post-injury, when he had a continuous pain and the same swelling, no improvement, so he went to another surgeon where these weight-bearing X-rays were done, and it was found that there is something problematic at the base of second metatarsal, but still the injury was not cleared. He started walking on the deformed foot and developed this kind of deformity after 45 days, and these were the full weight-bearing X-rays showing clear-cut instability of the tarsometatarsal joints, maybe at the level of cuneiform also with the dorsal subluxation of metatarsal. I mean a whole package of a radiologically evaluated Lisfranc injury. This is what has been done at the other center, saying that it is just a 6 weeks, the deformity is flexible, it has moved too much, so it is flexible, and this is what has been done. With the percutaneous K-wire fixation without opening the joint, and this was the radiological parameters which where we assess whether the reduction of the Lisfranc is acceptable or not, and it is clear in the audience that it is not acceptable. So now it is 2 months old injury. He came to us, we removed the K-wire, we got a CT scan, and the CT scan was showing that these are the level of comminution, some dorsal subluxation, clear diastasis between first and the second metatarsal, comminution at the base of second metatarsal. We got an MRI also because he is a young champ. So we wanted to know whether the cartilage status is good or not, and these are the area of the subchondral changes which has been developed at the end of 2 months. Maybe some manipulations by multiple manipulations by the K-wire has increased more injury level to this cartilage at the end of 2 months. So he has been planned for the fusion because this was really a non-salvageable at the end of 2 months because of these kind of changes in the CT and the MRI. And look at the foot level, this was abducted, and instability was assessed intraoperatively because it was 2 months, and we achieved that there is a lot of instability. I mean, a kind of flexible instability was still present on intraoperative situation, and this was the diastasis level. TMT joint instability, this is called piano key sign, was still present at the 2 months, and this is the dorsal subluxation of the second metatarsal. Intercuneiform instability was still there between medial and the middle cuneiform, and they were moving like a chunk, and there were a lot of fibrosis between the tarsometatarsal joint and the intercuneiform joint, which was taken out. Cartilage was removed, which was visible and was really bad. Locking plates were applied in intention to the fusion. Some synthetic bone graft were also used to bridge that small gap. This is how the closure has been done. This is a functional outcome, showing a good range of motion of the ankle, toe movements. They were full, talonavicular joints, chopper joints were full, 8 weeks follow-up, good fusion, pain-free movements, walking, full weight bearing, 6 months, good consolidation of the TMT joints, 8 months, plantigrade foot, walking, full weight bearing. So for the missed and the maltreated Lisfranc injury, conclusion is we cannot salvage them. Sometimes it's a very poor options of salvaging those bad TMT joints. Fusion is a viable option. Meticulous joint preparation is important. Plan for some defects and the bone graft because it's old injuries, and rigid reconstruction is important. Thank you.
Yeah, thank you. Thank you, Dr. Girish.
Yeah, at the end, I would just request, sorry, can you please show the last slide? Yeah, it's outside. I would request that next year, Indian Foot and Ankle Society conference, annual conference, we are going to organize in Nagpur, and you are heartily welcome. The registration link is open on the website. Thank you.
Yeah, you can ask questions to the speakers.
So we had talked about salvage of neglected ankle, that of calcaneus, that of talus, that of metatarsal, and Lisfranc we said that it is not salvageable if it is neglected. So you can address your question to anyone out of us you feel.
Asim, you have put a syndesmotic screw. Is there a criteria for putting that in a neglected bimalleolar or trimalleolar fracture where you yourself in a CT scan have said the mortise is looking good?
I'll agree,
The
probably it wasn't required.
Okay.
Yeah.
If
Agreed.
they can open your presentation on slide 2.
Yeah. Can I answer this
Yes,
question?
yes,
Yeah.
sir.
In a neglected case, even if syndesmosis is good, well aligned, I like to put in 1 or 2 trans or fibula protibia screw that augments the stability of the fixation. So, if I happen to be on his place, I would have put in minimum two fibula protibia screws to augment the stability. So I feel that fixation is been helped by your screw.
Asim, hold on, I'm justifying. In the intra-op C-arm pictures, if they can open out, the criteria what you have laid down, the tibiofibular space is more than 5 millimeters.
4.
Okay.
Yeah.
No, the true mortise view on the C-arm, intra-op, slide number 2 or 3 which you have shown.
Yeah.
So which suggests there is an instability, 1. Second, the medial clear space is more than obviously 4 or 5 millimeters.
The whole construct has
No,
shifted.
I agree.
Yeah.
So now these are 2 criteria on which we can say there is a syndesmotic injury. And the CT scan, the fibula is in the incisura. Or maybe a millimeter more, it has widened out.
In good position, yeah.
So how do we decide that? Very often we have a situation while all of us are fixing a trimalleolar fracture where the fibular fracture is above the syndesmosis. There is a posterior malleolus which is very small, which falls back in position, and there is not, and when you check the dorsiflexion view, there is the medial clear space is normal. So how do you decide on table whether in those situations you need a syndesmotic fixation?
Even the smaller ones, as a religion, something like 10% also of posterior malleolus, I do an open reduction. So I have stabilized that. Quite often in a fresh case, having fixed all 3 components of the injury, I don't use anything, no syndesmotic.
No, my question is not
here
that.
it's different. Here,
Asim, my question is not that. After having fixed the fibula, after having fixed the medial malleolus,
and the posterior.
The posterior malleolus is a too small a fragment, right? Or you on table you do a dorsiflexion, the ankle is stable, the mortise is stable. Do you still feel when the injury is above the syndesmosis, the fibular injury is above the syndesmosis?
If in doubt, I will put it. You should stress all your fixations in
the doubt,
coronal sagittal axonal rotation.
I'm giving an explanation. There is no doubt. After the fixation, the medial clear space is normal, as good as the other side. Okay. The tibiofibular space is normal, and still you have a small fragment of posterior malleolus.
Sangeet, we are repeating the same thing. If there is a gray area, I will play it safe and put the screws. I can always take it out.
I agree.
Yeah. So there will be gray areas. But if I am 100% confident, having fixed all 3 components, almost 80% of the times I don't use the syndesmotic screw because I am very sure. Yeah. If in doubt, I will put it.
Dr. Negi, if you have fixed everything and your syndesmotic fixation is also very good, you have done everything properly, still your mortise is not anatomic, what could be the reason?
I will go back to my original planning. Probably I have goofed up somewhere, and if required, I will take that anterolateral orthotomy for the syndesmosis, open that area, see it. Either my fibula is mal rotated or is short a few millimeters.
More than
in
that,
a fresh case, that is the only thing. Because posteriorly, I always take a posterolateral approach. Even 10% PMF I fix. Open, reduce, and fix it.
Yeah, Mason's classification tells us that smaller the fragment, more is the chances because there is an attachment of PITF.
Yeah. But more in the
But my question was that if you have fixed everything very nicely, your length restored, rotation restored, and still you feel that your mortise is not anatomic. There could be two situations.
Something interposing there.
There could be two situations. Deltoid integrity is lost, or ATFL, anterior talofibular ligament, is not in, it is lax. So these two things, when you feel that you've done everything and still it is not falling into place, look for these two things. They could be going haywire. And you might as well require to go in and do reconstruction of the deltoid or reconstruction of ATFL.
You are talking about a medial malleolar fracture with a deltoid incompetence, or it is not there?
Yeah. Even with the Stilwart in his article showed that even if you have a medial malleolar fracture,
Still it can be.
Still there could be a
It
deltoid.
can be incompetent.
So the message is stress your ankle fracture at
planes.
every level.
Yeah.
You fix one, stress. You fix second, stress.
And AITFL, I will choose to open it. It's hardly 5 minutes job. You just see it and put it back and put a screw with a washer.
Abhishek would put in a scope and do it. Right?
Yeah.
Dr. Negi, you showed a 2-year follow-up case. Still you having that centimeter screw. What is the protocol of your
She has not turned up. She has to be invited. Please come for a free consultation and an X-ray. She refused. She is not from Indore. She is from Hyderabad.
So what is the protocol about the centimeter screw when you remove?
I explained to the patient that it may break. If recently there was a patient, I discussed with him also, and patient was doing kuku. So after 4 months, I would like to remove it, not at 8 weeks or 10 weeks. If it's troubling him, otherwise, as a rule, I don't encourage them to come for a removal.
So
this lady is happy. She has not asked for a removal. Actually, I bribed her. No fee, free X-ray, everything. Please come and show me.
By and large, if the patient is not getting ankle dorsiflexion at the end of 4 months of your good fixation, I feel that I need to go in and I remove my syndesthetic screw. Because you might have over-tightened it. That otherwise, let it break.
Sir, when you are pulling out the fibula to the length, how do you assess the rotation of the talus within the mortise? Do you do it before you put the screws in the proximal fibula? And because if you fix the fibula slightly anterior or slightly posterior, the talus will be rotated in or out, and I find it very difficult to assess.
Open reduce the syndesmotic part. Either by taking a slightly atypical incision, J-type, where you can use the same incision, or if you have gone way posteriorly, then you take a small anterolateral orthotomy, separate too. Or some people, they like a single incision which exposes the fibula and that anterior part of the syndesmosis. Both. Raju Bhai likes to put a anterior K-wire so that it doesn't... Yeah.
So I put in one K-wire which will fix my syndesmotic
temporary K-wire.
Temporarily, and I'll put a K-wire which is flush to the anterior border of the fibula. So my screw is going from posterolateral to anteromedial. I don't want my fibula to slide. And you see this plane mobility is more, instability in a sagittal plane is more than the mediolateral plane. That's why I do this.
Plus length you tend to lose. So if you have lengthened the fibula, you just from the distal part of the fibula, you pass a wire, transfixing wire in the talus, which you can remove afterwards. Otherwise, you lengthen it, and finally you may end up with a short fibula.
Abhishek, were you happy with the reduction? The last X-ray, the axial view, shows a significant step. The wall, the displacement is not completely corrected.
No, the medial step you meant?
Yeah. That axial view, the last picture, what you have shown, there is a significant step. Is it acceptable in that 24-year-old?
So when we moved it, that was a gap that was there. So on the medial wall, because of the varus tilt, when I got it to length and corrected the alignment.
It was, Girish, it was on the opposite side of the plate.
That's the medial side. Yeah, medial side.
Yeah, that step, which was there in the pre-op X-ray as well.
Correct.
So you have not been able to.
No, sir. It was not an intra-articular step. It wasn't. It wasn't an intra. It was on the wall.
Okay.
It was on the medial wall that. Because I got it corrected it.
Right.
Abhishek, how often have you noted that in spite of, and more so in such cases, right, in spite of getting a good reduction on table, you have some virus at the end of few weeks when you see your X-ray, more so when you compare it with the opposite side.
Correct. So I have learnt it by my experience. So this time I had put one wire holding onto the talus. So there are papers, this kind of philosophy is also seen in an HTO. That's why on the lateral side, they pass one axial screw to hold it and make it like a bicolumnar fixation. So in calcaneums, when I'm doing a refix or a revision or something, I pass one axial screw only up to the subarticular facet on the medial side to prevent this medial collapse in future.
Yeah, so typically I have believed that it is like a bicondylar tibia fracture. Your plate is on a lateral side. Is probably not enough to really, take virus into the proper position. So even if I am doing a fresh calcaneus or I am doing MIS calcaneus or revision calcaneus, I almost always put a fully threaded screw just flush to the medial border of the calcaneus, so which prevents the virus.
Abhishek, it wasn't only virus. At 3 months, the tendoachilles is also sort of shortened. So how could you bring that out to length?
So I was prepared for a fractional lengthening, but because I had got my angles which I expected to achieve on table, I didn't do it. But otherwise, that is one of the first steps that you need to do to get it down and proper calcaneal pitch.
You have done that, and if in that struggle, because time consuming and surgery which is not easy. So if it completely ruptures, then it doesn't make a difference?
It does definitely
because it's
make a
percutaneously.
No, I don't do it percutaneous. So I do it open.
Then it's fine.
Always.
Sorry. So my question is a continuation of the syndesmotic discussion that we are having. So if it is a Cotton's fracture, the posterior malleolus is a big chunk. And what is the firstly, what is the steps of fixation? Posterior first, lateral second, and medial, or lateral first, posterior second, and this? And once I have reduced the posterior malleolus anatomically, the fracture is at the level of the syndesmosis, then do I need to put in a syndesmotic screw which is a little higher, because otherwise that syndesmotic screw goes very close to the fracture site. So then it hampers in the healing of the lateral malleolus. So what is your...
First thing.
Yes.
Once posterior malleolus has to be fixed, your approach is decided. You are going by posterolateral approach. Yes. Okay? You have to see the posterior malleolus, and like a volar Barton at the wrist, you have to do a metaphyseal reduction. Right. Usually with a thumb pressure, up to 2 weeks, it will come. And then I take a 2 mm K wire and under image intensifier, which is in the lateral position. It's a floppy lateral type of position I do. I don't do them prone. So under image intensifier, just subchondral 5 mm above the articular surface, I shoot that wire. And I keep in mind that I'm going to put a T-plate there. So it's in the meat of that. Then I reduce my fibula, hold it with K-wires or clamps, but I don't put my plate on the fibula.
Okay.
Because that will hamper my radiology of the posterior malleolus. But I reduce it, hold it with at least 1 or 2 clamps and 1 or 2 K-wires, which at times I shoot and bring them out anteriorly if they are hampering my operation. Then I slide a plate, T-plate, distal radius plate over that. And it's a 3.5 plate, it's not a rigid locking plate, which has got a shape which easily molds and will contour and act as an anti-glide plate. Then I pass by metaphyseal screw. Okay? Proximal.
Cortical, yes.
For that thing. There is already a wire holding it. I pass another, out of the 3 holes, I pass 1 more hole, K-wire only. And I'm holding my posterior malleolus with the clamp in the plate hole. So my plate doesn't become, the plate stays flush. There are 2 wires holding the posterior malleolar reduction. Fibula is already reduced. Then I pass my anti-glide metaphyseal screw and substitute these two K-wires with, and then I go on the, and then release the tourniquet, achieve hemostasis, close that wound and turn the patient supine.
Okay.
Yeah, that will be.
And how about the syndesmotic?
Hemostasis thing, it's not necessary to pass it 2 centimeters above. You can pass it higher up also. Every ankle fixation has to be stressed in AP, lateral, and coronal, sagittal, and with external rotation force. All ankles. And if there is something going wrong, even the ankle has subluxated after fixing everything.
So even if we fix the posterior malleolus, we would still add a syndesmotic screw.
Most of the time I don't.
Most of the time you don't.
But I am very cruel in assessing the stability.
Right.
Yes. Thank you. Last question, please.
Question to Dr. Rajiv Shah. You said about total talar replacement. You said one size up and one side down. You usually keep it on table. And what metal do you use for total talar?
Medical grade titanium.
Titanium.
Medical grade titanium.
Okay. Thank you.
Okay. Any question? Okay. We close this session. Thank you very much.
We have 10 more minutes. You can grab a cup of coffee or something, and we start at 3:40.